Thank you so much, and thank you and Dr. Karthikesan for the kind invitation. It's a privilege to be speaking here today. I'm just going to share my screen here. Okay, hopefully you can see this here. Okay, perfect. Can you see my screen?
Yes, we can see.
Great. So my topic in 15 minutes is when do I recommend AF ablation, current evidence, and future technologies? And these are my relevant disclosures. I do serve as national PI on an ablation study using pulse field technology, which we'll talk about. But as you can imagine, for anyone that does, AF ablation to the numbers that we do in the U.S., the answer would be we recommend AF ablation in everyone. But that isn't quite the reality. But hopefully,
sorry to interrupt you, Shephal. Doshi. Can you go on?
Can you hear me,
Dr. Shephal Doshi? Can you go to the slideshow mode, please? You're on the normal mode. Can you please go to the slideshow mode?
This looks like slideshow for me. Is this slideshow for you?
Yeah, right now, yes.
Okay,
yes,
great.
now.
Okay, perfect. So my outline is briefly just to cover again, review the concept of AF ablation, and hopefully with the evidence and seeing the future technologies, you will see why it is not uncommon for many of us to be doing over 100, 150 ablations a year, 100, 150 Watchmans a year. I think the data does support that if you choose the patient correctly, the results and the efficacy would encourage us to do more procedures. So let's just focus briefly on the mechanism of atrial fibrillation. I mean, the theory has always been that atrial fibrillation is a very chaotic, disorganized rhythm, multiple wavelets. This is one of the original hypotheses from Gordon Moe in the late 50s. But I think we recognize that no longer do we tend to think of atrial fibrillation necessarily as a random and non-focal arrhythmia. As a matter of fact, because of this randomness in nature, traditionally the surgical technique involved commonly the Mays procedure, where the atrium was compartmentalized into small sections to basically reduce the amount of arrhythmia that could communicate with the rest of the chambers and minimize atrial fibrillation recurrence. And this tended to work really well. However, it was fairly invasive. And I think the big landmark, as with many things in EP, comes out of Bordeaux. But in the late 90s, there was emerging data that atrial fibrillation, especially in the paroxysmal patients, many of these cases originate from ectopic beats originating from the pulmonary veins. So the question was always, how do these veins generate and conduct electrical impulses, right? And what we recognize from pathology is that there is a very unique and interesting organization of muscle sleeves from the atrium into these venous structures. So you can see the upper pulmonary veins, which are at the top here, have larger muscle sleeves typically than the lower pulmonary veins. And you can also see a sizable amount of muscle sleeves in the SVC, less so in the IVC. And what they documented was the concept of the PV here, starting out with a focal trigger firing very rapidly, rapid enough to basically convert the atrium into a chaotic, somewhat disorganized rhythm, atrial fibrillation. And so the way they study this, just for a brief review, is they placed a spiral-like catheter called a lasso catheter in the pulmonary vein. And what they showed in this slide, for example, was that there were impulses emanating from the pulmonary veins that would then degenerate into atrial fibrillation. And they saw these also here, as you see the first impulse is a sinus beat. And then you see that the sharp electrogram is the near field electrogram coming from the pulmonary vein. In sinus rhythm, the signal in the pulmonary vein comes after the left atrial signal. Here you see the pulmonary vein is leading, triggers an atrial fibrillation. And then we also saw PACs, as you see here, where you see again the near field sharp electrogram coming first, suggesting this came from the pulmonary veins, again degenerating into AFib. The other theory that I think that's really important for everyone to understand is the concept that AFib begets atrial fibrillation. And what that means is in this study, for example, where we took sheep and we basically exposed them to very rapid burst pacing. And if they were exposed to burst pacing for a few seconds, they immediately converted back to sinus. If you burst pace them for 24 hours, it took a little longer from them to convert into sinus. But if you rapidly pace them for 2 weeks, then many of these sheep would stay in atrial fibrillation for a long time. And so the more atrial fibrillation you have, the longer you are likely to sustain atrial fibrillation, hence making it less likely for you to convert into sinus rhythm. And this is part of the concept that we have, that we want to treat this atrial fibrillation early in the process. And so we always encourage our cardiologists that if you have a symptomatic AF patient, don't wait till they've failed 3 drugs, don't wait till they've had 2 cardioversions, send them to the electrophysiologist straight away, because the earlier we intervene in the symptomatic patient, the more likely we'll have success, and we'll talk about that. So the theory really is that the posterior left atrium and the pulmonary veins, and I think this is well established now, act as triggers and drivers for atrial fibrillation. So this is based on clinical observations, and this is based on experimental evidence. So the concept is as follows. If you look at the CT scan here, looking at the posterior left atrium, you can imagine triggers coming from these veins. The superior veins are more likely than the inferior, but they all seem relevant. And you see the rotors of activation in the posterior wall. And in the very initial concepts of this kind of theory, we would simply try to identify the focal area inside the vein and ablate that vein. And what we saw was very high levels of clinical recurrence. And then we recognized that it wasn't just one spot in the vein, but different areas in the vein. So then we decided that if we're going to do this procedure, we're going to isolate the particular vein. And so we would do single vein isolation on these patients because those are the veins that we would induce. In electrophysiology, we were always used to actually the science of it. So we'd have to induce the tachycardia, induce the arrhythmia, find the location, and ablate it. So in this scenario, this was the concept. And what we recognized is that when patients recurred, they often had firings and triggers from other veins. So then we decided anatomically, doesn't matter what vein is firing, we're going to isolate all 4 veins. And it took nearly a decade for the field, based on multiple studies, to finally agree that the foundation of AFib ablation is to electrically isolate the pulmonary veins. Again, these are in non-valvular AF patients primarily that were studied. Okay, so the concept, as you see here, is imagine these are your veins that are firing triggers, and those dots are the areas that you have ablated such that there's electrical scar, you're not able to conduct electricity, and these rapidly firing potentials stay trapped inside the pulmonary veins and don't make it out into the atrium, right? And so this is that concept that we talked about. So as you can see from an electrophysiologic procedure, that arrow is pointing to the sharp pulmonary vein electrogram. And once you ablate all around the vein such that no potentials can come out, what you'll see is that sharp electrogram is gone. And that's pulmonary vein isolation. Okay. And even dating back, and these are some older studies, but just showing you how far back we have the data of the effect of a successful ablation versus medical therapy. And you see the improvement in so many factors. It's not about just looking at and all the time at mortality, but oftentimes it's looking at quality of life and improvement in symptom severity, mental component, et cetera. So all of these relative to antiarrhythmic drugs, which are in red, were favorable for the catheter ablation arm. And the 2 pivotal studies in the United States, which led to approval for catheters for ablation, are shown here. And the left is a thermocool IDE study using radiofrequency irrigation ablation. And on the right is a cryo-stop AF study using a cryo balloon. Again, in both trials, the goal was pulmonary vein isolation. Now, the challenge with all of these studies in atrial fib is we're looking at a clinical endpoint. However, what we're doing procedurally is simply isolating the veins. And if you look at the data now relative to the data then, our success rates seem to be better. Is it because we're doing anything different? No, we're still doing the same thing, but we're better at it. Or I really think our endpoint should have been the efficacy of actually isolating the veins, not fixing atrial fib. And what you find is that our success rate with advancements in technology allow us to have a better rate of isolation of all 4 pulmonary veins in patients. And so if you look at the current trials in atrial fibrillation ablation, there's many new trials that have been recently published or presented. This is the East AFNet 4 trial published in the New England Journal in August, of which there was an update at the recent Heart Rhythm Society meeting just last week. And this study basically looked at early rhythm control versus usual care. And about 20% of these patients actually had ablation. But the point is that treating patients early resulted in a better outcome, primary outcome, looking at stroke, cardiovascular death and hospitalization. Along with these trials, there have been other trials that have been published recently, and especially in heart failure, which we talked about earlier, ablation versus drug therapy. We see that early ablation in heart failure patients and cardiomyopathy resulted in an improvement in clinical outcome relative to drug therapy. Again, a repetitive theme. If you're looking more at a recent meta-analysis published by the group out of Mount Sinai, looking at 6 large catheter ablation trials versus antiarrhythmic drugs, led to the conclusion, and I think this was very consistent, that, again, catheter ablation led to reductions in recurrence for atrial arrhythmias, reduction in hospitalization with no major adverse events. And if you look at multiple prospective randomized trials of antiarrhythmic drugs versus ablation, I think it's very clear now in 2021, and based on the guidelines, that ablation becomes a first-line therapy for many patients, not all patients, but for many patients with rare exception, which we'll talk about in the future in the upcoming slides. Okay, and so if you look at simply the strategy alone, I think the one thing that has panned out is consistency, that all the patients at a minimum should have pulmonary vein durable isolation. That is isolation that isn't just there for 5 minutes, but actually is there for the rest of their lives. And ideally, it would be great to be able to do that on the first procedure. What are the technologies? Some of the improvements. This is showing catheter ablation using more current technology with force sensing. So now the operator is able to gauge how much force they're putting on the tissue, because we know that when you're doing radiofrequency and resistive heating of local tissue, the more force you have, and that is grams on the tissue, the more likely you'll make a better lesion. And this is using radiofrequency. Another technology which has gained momentum is the use of cryoablation, which is more of enabling technology. You're basically wiring the pulmonary vein and advancing the balloon into the vein to electrically isolate, and by basically freezing. So here you see in this animation a catheter, again, being inserted in the left pulmonary vein, and then you insert a mapping or a diagnostic catheter into the pulmonary vein, and then you advance the balloon into the vein, and then you inflate the balloon and basically freeze using liquid nitrogen the tissue that's in contact with the balloon. And typically it requires a 4-minute freeze, and if you would like, you can do a second 4-minute freeze, but usually in a very consistent fashion, one is able to electrically isolate these veins using cryothermal energy. And you can see here the vein is occluded, and then you see an ice ball forming on the cryocatheter, which after 4 minutes permanently ablates the tissue, as you can see here. So if you think of the concept, why does ablation fail? One of the big issues is this is our goal, is to electrically isolate these tissue in the veins. But what can often happen is as you're making lesions, you can have edema. And as that edema resolves, maybe a week later, maybe a couple of hours later, maybe a day later, you recognize there's a gap in your conduction line and patients can have recurrent atrial fibrillation. And so the question is, how can we improve this? How can we make more consistent permanent lesions on the first try? And this is an example of a patient of mine who had PV isolation done. And you can see the circuit, basically it's going from the color red to orange to green. And you see these are the pulmonary veins in the left. And there's a small gap that basically allowed this pulmonary vein tachycardia to continue. And the patient had recurrent atrial fibrillation. So it's using these novel technologies that I talked about that has helped us get better. And this is just one example of using force sensing. And this is a catheter advance, and these catheters either have fiber optics or they have a spring mechanism inside, so they can actually gauge how much force you're putting on the catheter on the beating heart, and you can advance or pull back the catheter depending on how much force you want to give on a given location. So AF ablation efficacy is really highly dependent on patient selection. Obviously, the more paroxysmal you are, the success rates will be higher than those that have been permanent for years. Left atrial size has an impact. Whether they have active significant regurgitant valve disease has an impact. Left atrial fibrosis has an impact. And there are novel technologies which have really helped us have better efficacy. And we've talked about some with RF using cryoballoon, but also laser. And I think the future is going to be irreversible electroporation, or IRE. And just in a minute, we're used to reversible electroporation, like defibrillation, where you can temporarily disrupt the cell membrane to allow therapeutics. And this is what they use in cancer treatment to allow the therapeutics to enter the cells. What we're doing is irreversible electroporation, tissue specific. So we basically cause permanent cell death on cardiac tissue, but preserve the tissue around it, that is pulmonary tissue, esophageal tissue, less likely to cause collateral damage. Here's the concept of a laser balloon, where you have an endoscope inside the laser. And so you can see as you're ablating, here's a balloon being inserted in a pulmonary vein. You can see the balloon is then inflated with D2O, or heavy water, that you can see with contrast. And then one is able to emit laser to create thermal heating. And finally, in just a few seconds, the future, I really think, is in the hands of irreversible electroporation. Imagine putting a catheter in that selectively injures only cardiac tissue and no other collateral tissue. Obviously, the excitement is a bit early. We're doing large randomized trials in the US. There have been some smaller studies done in Europe, but this is very encouraging. So in conclusion, when do I recommend AF ablation? Again, it's a lot to talk about in 15 minutes. We consider it, even based on the guidelines, as being first line in any symptomatic patient, except maybe those with severe comorbidities, limited longevity, long-standing permanent atrial fibrillation, untreated severe valve disease, and extreme atrial enlargement. You see in the US where the numbers are in 2021, if it's not even with the pandemic, we expect over 200,000 AF ablations this year. Worldwide is over 600,000. Consistently the largest EP ablation growth area, largest cardiology growth area with more operators, but we need more enabling technology and need improved efficacy. Thank you so much.